Good afternoon, good evening, everybody. Welcome to this session of Diastology of the 44th Comprehensive Course on Echocardiography online program, which is going on right now due to COVID pandemic. We have with us none other than Dr. Debika Chatterjee, who is the Senior Consultant and Head of the Department of Non-Invasive Cardiology at Rabindranath Tagore Institute of Cardiac Sciences at Kolkata. A very devoted cardiologist looking after non-invasive cardiology. And on top of that, one of the finest person I ever came across in my career. And she is the one who has been doing a lot of work in echocardiography and allied specialties, apart from its clinical correlation at her institute. With this few words, I would like to invite Dr. Debika Chatterjee to take up the session of assessment of a diastolic function by echocardiography. And after the session is over, we'll take up the question answers. So be attentive. And if you're not going to be attentive, I'm going to ask a couple of questions this time from the delegate based on our talk. With this few words, Dr. Debika, it's all yours.
Thank you, sir. Thank you for that kind introduction. And hello, everybody. Good evening. Very good evening. Without any introduction, I'm going to start the session. It is the assessment of diastolic function by echocardiography, which is an integral part of the subject echocardiography. Every day in each and every patient, we do the assessment of diastolic function. Now, let me start with a patient who is a 60 years old obese male presented to us with history of hypertension, with a complaint of progressive exertional dyspnea with fatigue. And on examination, you get a bilateral ankle edema, hepatomegaly, and bilateral crepitations. So obviously the diagnosis is congestive heart failure. The next important question is, what is the cause? Whenever we get a patient of heart failure, we have a habit that we think this might be systolic dysfunction. And we look for the systolic function in the echocardiography. Here are the views to look for LV ejection fraction, LV contractility. This is the parasternal long axis view. This is LV. Both the anterior septum and the posterior wall are contracting very well. And look at this short axis at the papillary muscle level. All the segments are contracting. Look at the systolic thickening. All the segments are contracting very well. So also in the apical four-chamber view, where you can see the septum and the lateral wall, both are contracting very well. You can see the excursion of the endocardial margin, and also in the apical two-chamber view, where we see the anterior wall and the inferior wall. So I have looked at almost all the segments of the left ventricle, and I find that systolic function is absolutely normal. Now, as I do the Doppler echocardiography, and then first thing I rule out left to right shunt, which might have caused the shortness of breath in that particular patient. I also rule out right heart pathology by like tricuspid valve disease, etc. Then I find that the patient is having diastolic dysfunction with elevated LV filling pressure. So basically, this patient is in diastolic heart failure with preserved ejection fraction, or a term called HEP-PEF. This accounts for 40 to 50% of all heart failure. Almost half of the cases of heart failure is due to diastolic heart failure with preserved ejection fraction, or HEP-PEF. And this is responsible for significant mortality, morbidity, and recurrent hospitalization. And the prognosis is as bad as systolic heart failure. So we need to know how to assess the diastolic function in this group of patient. Because when a patient with shortness of breath due to heart failure comes to us, we have to answer a few questions in our mind. First of all, is this patient truly have the HEPF? Is the patient's shortness of breath is due to HEPF or due to some other cardiac or non-cardiac cause? We also need to know the hemodynamics in this particular patient of heart failure, because we have to optimize the unloading therapy. And also the hemodynamics will give us the idea about the prognosis and will help us in follow-up of the treatment. Now, it is the echocardiography where with the help of echocardiography, we not only get the idea about the structural problems of the heart, we also get to know the functional problem associated with the diastolic dysfunction in that particular patient. When I say functional problem, I mean it's the LV filling pressure, because it is the elevated LV filling pressure which is the final common effect of diastolic dysfunction. As I'll go forward with my presentation, you would see how elevated LV filling pressure changes the scenario of diastolic dysfunction from grade 1 to grade 2 to grade 3. And it is the elevated LV filling pressure which results in shortness of breath in HEPF. And also a raised LV filling pressure is a marker of poor prognosis in this group of patient. So and moreover, as per the latest recommendation of AEC for evaluation of left ventricular diastolic function by echocardiography, the grading of diastolic dysfunction is based on the presence or absence of elevated LV filling pressure. So you need to know the LV filling pressure. And in your diastology echo report, when you make a comment on the diastolic function, you not only mention about the presence of diastolic dysfunction, you also mention about the status of LV filling pressure. And that will automatically grade the diastolic dysfunction. You need to mention whether the LV filling pressure is normal or elevated. So these are the things which you must remember while giving the report for the diastolic dysfunction. Now let us recapitulate a little bit about the applied physiology of diastole, because you will need this knowledge for assessment of diastolic dysfunction by echocardiography. As we know that diastole is the phase of relaxation. It starts with aortic valve closure and it ends with the mitral valve closure. And it is the process by which heart returns to its relaxed state. Now let us see what are the phases of diastole. See, diastole always starts with isovolumic relaxation phase. As soon as the aortic valve closes, this isovolumic relaxation phase starts. In the myocardium, there is active relaxation of the myocardium because of removal of calcium ion from the troponin C, as a result of myocardial relaxation, LV pressure falls. Now, a time comes when the LV pressure goes below the left atrial pressure. So that is the moment when the mitral valve opens. And because of the difference of pressure, because the LA pressure is higher than the LA pressure, and we know that blood always moves from the higher pressure zone to the lower pressure zone. So what will happen? Now the blood will start flowing from the left atrium to the left ventricle. Around 80% of the left ventricular or ventricular filling takes place during early rapid filling phase. If you look at the LV pressure curve, this is the early rapid filling phase. Look at the curve, how steep it is, and these results in the E wave when in the pulse Doppler of the mitral inflow, which I'll show you in the subsequent slides. So the early rapid filling phase gives rise to the E wave. Now we see that 80% of the filling of the ventricle is complete in early rapid filling phase normally. So as a result of that filling, the LV pressure again rises and it goes, there is almost equalization of the pressure inside the LV and the LA. There is no, positive force to drive the blood from the LA to the LV, no pressure difference. So blood flow decelerates. So in the next stage, we get the diastasis. The blood flow decelerates, and this is the phase of diastasis, where there is no flow. The mitral valve remains in semi-open condition with the equalization of pressure of LA and LV. But if you remember, the 20% of the blood is still remaining in the left atrium because the LV has received only 80% of filling in the early rapid filling phase. So that rest 20% of the blood is ejected from the left atrium to the left ventricle by active pump of the left atrium, or atrial booster, as we say. And that gives rise to the late diastolic filling phase of the ventricle. If you see here, this is the atrial contribution, and in the echocardiography of the pulse Doppler of mitral inflow, we see the A wave. So A wave corresponds to the late diastolic filling phase. Now, if we look at these different phases of diastole, we find that there are two factors which are actively involved in the process of diastole of the ventricle. One is the relaxation, as I said, which is an active relaxation, and it is the ability of the myocardium to relax during diastole because of removal of the calcium ion from the troponin C. And another is the compliance. As the blood is moving from the LA to LV, LV should be able to receive that blood. So it is called compliance, or the distensibility of the relaxed ventricle. It is the response in change in volume to change in pressure. Imagine you are inflating a balloon. Now, if the balloon is made up of thin rubber, if you push the air, the balloon inflates. But if the balloon is made of thick rubber, even if you apply pressure, the balloon will not inflate because it has lost its distensibility, it has lost its compliance. So for a normal diastole, we need a normal relaxation and a normal compliance of the ventricle. Then only we'll have the adequate LV filling without increased LV filling pressure at rest as well as at exercise. If that doesn't happen, if there is delayed relaxation or reduction of compliance of the LV due to stiffness, as I have already explained, there will be impairment of the LV filling in diastole, and that will result in increased filling pressure for a given volume, as I have explained while explaining the compliance, and that will indirectly increase the LA pressure. LA will undergo remodeling. It will be enlarged, and that will lead to pulmonary venous hypertension, and that results in diastolic heart failure of the patient, which happened in our patient, which I showed you at the beginning. So after having this knowledge, let us see what are the causes of diastolic dysfunction. If you look at this chart, old age tops the list. It is at the top of the list. You must be knowing that there are certain changes in the heart and the vascular system which is associated with old age. There's a normal physiological process. Uh, the myocardial relaxation also gets impaired as we get older. Just like graying of our hair, muscle relaxation, myocardial relaxation also is impaired. So in a patient of more than 60 years, you may get a mitral flailing pattern showing impaired relaxation. But if that impaired relaxation pattern you are getting in a young man of 35 years, that is not normal, that is abnormal. So while assessing the diastolic function, the age factor should be kept at the back of the mind. Impaired relaxation pattern is a normal finding at old age. You must be aware of the age. Second cause is the long-standing hypertension. As happened in our case, that was a patient of long-standing hypertension. That will result in the changes in the myocardium because of the thickening of the myocardium. Also, the cardiomyopathy of different causes like hypertrophic cardiomyopathy, restrictive cardiomyopathy, infiltrative cardiomyopathy. Here, the myocardium cannot relax. Even in diabetic cardiomyopathy, the myocardium cannot relax. Similarly, coronary artery disease, where we get the ischemic myocardium or a scarred myocardium due to myocardial infarction. Those myocardium also cannot relax and we get the diastolic dysfunction. Constrictive pericarditis is an extrinsic cause. As you know, it hampers the left ventricle from receiving the blood from the outside. And obesity and the sleep apnea are also the causes of diastolic dysfunction. Now, with this knowledge, let us start the echocardiography of a patient coming to you. See, we always start with two-dimensional echocardiography. So if you look at this patient, first you look at this patient, this is the parasternal long axis view, this is the septum, and this is the posterior wall. So if you look at the septum, there is asymmetrically, septum is asymmetrically hypertrophied. Posterior wall is normal in thickness. So it's a case of asymmetrical septal hypertrophy or a hypertrophic cardiomyopathy. So as I told you in the causes, hypertrophic cardiomyopathy is one of the causes of diastolic dysfunction. So you start thinking that this patient will have some degree of diastolic dysfunction. Same with this patient. If you look, this is an apical four-chamber view: left ventricle, left atrium, right ventricle, right atrium. Now let us concentrate on the left ventricle. You see the apex, at the apex, the myocardium is scarred. Large area of myocardium at the LV apex is scarred. So it's a large myocardial infarction in the LAD territory. Now this muscle will not be able to relax. So we get diastolic dysfunction. So we get an idea that these are the patients where will be getting, while assessing the diastolic dysfunction, you will remember that, yes, these are the patients will get some degree of diastolic dysfunction. Now, if we look at the two-dimensional echo parameters, it is the enlarged LA, which is a robust indicator of diastolic dysfunction. Because enlarged LA reflects the chronicity of raised LV filling pressure. So it's a chronic marker for raised LV filling pressure. It is, you see, it's a very, very powerful indicator of diastolic dysfunction with elevated LV filling pressure, and of course, in absence of anemia. atrial fibrillation, mitral valve disease, and in athletes where we may get enlarged LA. Now the question is, how do we measure left atrium? How do we say that left atrium is enlarged? Well, it's always the parasternal long axis view, which we start, and we measure the anteroposterior diameter from the inner edge to the leading edge, and we say, no, left atrium is normal or left atrium is enlarged. But if you look at the heart is a three-dimensional structure. So also the left atrium, it is a chamber. So it has got not only the anteroposterior diameter, it has a superior inferior diameter as well as medial to lateral diameter other than the anteroposterior diameter. And you may get some patients where anteroposterior diameter is normal, because heart is not getting, left atrium is not getting enlarged in the anteroposterior direction. It is getting enlarged in the superior inferior direction or medial to lateral direction. So as per the latest AAC guideline, the anteroposterior linear dimension should not be used as the sole measure of left atrial size. This is the normal as per the latest AAC guideline. So you should not only depend on the anteroposterior diameter. Then what should we do? We should measure the left atrial volume, and then we should index it by dividing the body surface area, by dividing the volume with the body surface area. So how do we do that? Please concentrate here. See, we do it by biplane area length method. When we say biplane, means we measure the volume in two planes. One is the apical 4-chamber and another is the apical 2-chamber. And the apical 2-chamber is the orthogonal view of the epi 4-chamber. So first, let us start with the apical 4-chamber. Now, see, we are measuring the LA volume. So LA should be in its maximum volume. So in which phase the LA is in its maximum volume? It is 1 to 2 frames before the mitral valve opens. LA is full with the blood. 1 to 2 frames before the mitral valve opening. So we will choose that frame with the help of ECG. Or you look at the LA, it is just 1 or 2 frame before the end systole. So what we do, we go to the septal annulus first, and then we trace the LA. This is the left atrium. Trace the LA, go round and round and round, exclude the pulmonary vein, and then we go to the lateral annulus. The machine joins these 2 points. We never join it. And then we get a length. So this way we get area 1 and a length in the apical 4-chamber view. We repeat this method in the apical 2-chamber view also, where we get an area 2 and a length. You see, so there are 2 areas, area 1, area 2, and 2 lengths. This is L, this is also L. Out of these 2, we will take the value which one is smaller. Okay, so we measure, the machine measures this length. You will see when you will do it in your machine. So out of these 2 lengths, we'll take the smaller value. But at the same time, you need to be careful that this difference of these 2 values should not be more than 10%. Now let us see what is the formula for LA volume. It is 0.85 multiplied by area 1, multiplied by area 2, and then divided by shorter value of the length of these 2. We get a value from this, and then we index this value by body surface area. The upper limit of normal is 34 ml per square meter of body surface as per the latest recommendation of AEC. So, but as you see, if you measure the anteroposterior diameter, you may get normal, but the moment you go to the LA volume, it may happen that you are getting a larger LA volume. So as for example, let us see this case. See, this is a patient where I have measured the anteroposterior diameter of the left atrium, and it measures 3.61 centimeter, which as per the latest recommendation within normal limits, because 4 is the upper limit of normal. Then I measure the LA volume. You see, this is the apical 4 chamber. I measured the LA volume in 4 chamber as well as in 2 chamber, and I get an area 1, area 2, and get a length here in the 4 chamber as well as in the 2 chamber. Look at the length value. In 4 chamber view, I got a length value of 5.38 centimeter. And in the 2 chamber view, I got 5.27 centimeters. So the difference is not more than 10%. So my value is correct. So I take the smaller value, 5.27, and then I get, the machine, calculates. All the machines are having now LA volume calculation. So the machine calculates the LA volume by biplane method. See, it's 46.6 ml. Then I divide that value with the body surface area, and that turns out to be 35 ml per square meter. So definitely LA volume is increased. So you have seen how anteroposterior diameter might be all wrong information in these cases. See, anteroposterior diameter was absolutely normal, whereas LA volume is increased because upper limit of normal is 34 ml. I mean, 34 and more than that is considered to be enlarged LA volume index. So in this case, I got 35. That means it is increased. So you have to measure the LA volume index along with the measurement of the anteroposterior dimension of the left atrium in the pasternal long axis. Now let us go to the next criteria for assessment of diastolic function. Well, it is the Doppler parameter. So what do we do? Look at this picture. This is the apical 4 chamber view. This is mitral valve. What I do, I put the color flow, and and I get the cursor, and in the cursor there is a sample volume. You must be knowing by this time. So I place the sample volume at the level of the tip of the mitral valve leaflets in opened condition. That means not here, not there, at the level of the tip of the mitral valve leaflets. And I get pulsed wave Doppler. Whenever a question of sample volume comes, it is always the pulsed wave Doppler. So I'm looking at the mitral inflow velocity. So pulsed wave Doppler at the level of the tip of the mitral valve leaflets. So normally, when I have explained you the phases of diastole, you must have seen that we get E wave and A wave. E from the early rapid filling phase, A from the late rapid filling phase. And E is more than A. So this is the normal pattern. Now, as the diastolic dysfunction sets in with the impaired relaxation, what happens? There is impairment of the LV relaxation. So LV pressure fall is less. So less pressure difference between the left atrium and the left ventricle, as a result of which small amount of the blood flow makes the pressure of LV and LA equal. So blood flow stops, and 20% of the filling instead of 80% is occurring at the early rapid filling phase. And the rest, 80% of the filling is taking place due to atrial pump or atrial booster in the late rapid filling phase. Now, what will happen when this pattern advances? The impaired relaxation pattern as advances, what happens? The left atrial pressure also starts rising. So when there is moderate increase of the left atrial pressure, again this E wave will be taller than the A wave, because left atrial pressure, since the left atrial pressure rises, so the pressure difference again becomes more. So more amount of the blood flows during early rapid filling phase, and A is small. So on top of impaired relaxation, because of the increased LA pressure in a moderate extent, we are getting a pattern where E wave is more than A. So this pattern is masking this impaired relaxation. Now, as diastolic dysfunction advances further, what happens? The left atrial pressure increases further. At the same time, left ventricle becomes non-compliant. So what will happen? Because of the significant rise of the LA pressure, the difference of pressure is very high. So there will be a quick increased flow from LA to LV, which will give rise to very tall E. But because the left ventricle is non-compliant, so there is quick equalization of pressure of LA and LV. So there is a quick deceleration that shortens the deceleration time. Now, the blood which is remaining in the left atrium will be pumped from the left atrium to the left ventricle. Though the left atrial pressure is very high, it's with the high pressure the blood is going, but LV is non-compliant. It is behaving like a balloon made of thick rubber. It's non-compliant. So blood is not able to move from the left atrium to the left ventricle. So we see, though the LA pressure is very, very high, but still left atrium is unable to pump the blood to the left ventricle because of LV non-compliance. So you see, impaired relaxation pattern once sets in, it remains in all the grades. It is the raised LA pressure which is changing the pattern. First to the pseudonormal, where LA pressure is moderately raised, and then the restrictive pattern, we say very tall E, short deceleration, and a small A, we get where there is very high left atrial pressure. So keep in mind that relaxation abnormality present in all grades of diastolic dysfunction. Now the question is, you see, these are the two patterns where E wave is more than A wave. One is normal, one we say pseudonormal. Now you are getting a mitral flow pattern which are quite similar. Now how do we differentiate? That we say this is normal and this is pseudonormal. So for that, let us see a case. This is a patient who is coming for a normal heart checkup, and look at the ventricle and the left atrium. It's absolutely normal. There is no thickening. Patient is not having that hypertension. A normal person, and I am getting E wave more than A wave. Now let us see the second case. See, look at this patient. Look at the septum. It's absolutely hypertrophied. So it's a case of hypertrophic cardiomyopathy. And look at the left atrium. It's so big. So in this patient, as I place the sample volume here and get the diastolic flow pattern, pulse wave flow pattern, I get again E wave more than A wave. Now I don't know whether this one is normal or this one is normal. How to say this can't be normal because this is a patient of hypertrophic cardiomyopathy. So how do I decipher? How do I differentiate between normal and the abnormal pattern? So one is the Valsalva maneuver. where we ask the patient to do the forced expiration with mouth and nose closed, like the way we strain on stool. And that maneuver is called Valsalva maneuver, and that reduces the preload. And another is with the help of tissue Doppler imaging of mitral annulus. So now, first, let us see how Valsalva maneuver changes the mitral flow pattern. This is the fast patient with a normal heart, normal history, and I get E wave more than the A wave. Now I ask the patient to do the Valsalva maneuver, forceful expiration with mouth and nose closed. As the patient does the Valsalva maneuver, look at the flow pattern. Here, the patient has started doing the Valsalva. Look how the E wave as well as the A wave are reduced in velocity. You see, keeping the ratio of E and A same. So this is a normal pattern. E wave is still high than the A wave, which we got before the Valsalva. And with Valsalva, also I'm getting E wave more than A wave, but velocity of both E and A proportionately are decreased. So this one is called normal filling pattern. This is the normal filling pattern. Now let us see the second patient. Second patient of hypertrophic cardiomyopathy, where I got a normal pattern, but I said it might be pseudonormal. E wave was more than A wave. Now I asked the patient to do the Valsalva. Look at the pattern with the Valsalva. E wave is now less than the A wave. In the normal patient, we got the reduced velocity, but still E wave was more than the A wave. But here, E wave velocity has become less than the A wave velocity. So what is happening? With the Valsalva maneuver, we have reduced the preload. So that raised LA pressure factor is gone now. So that has unmasked the impaired relaxation pattern in this particular patient. So this is not normal. This we call pseudo-normal filling pattern, where we have unmasked the impaired relaxation pattern by asking the patient to do the Valsalva maneuver. So this way, with the help of Valsalva maneuver, we can differentiate normal and the pseudo-normal filling pattern of the mitral valve. Now let us go to the second parameter for differentiation of normal from the pseudo-normal pattern. Now, till now, we were talking about the pulse wave Doppler of the blood cells inside the cavity of the left ventricle. Now, tissue Doppler imaging is one modality where we don't measure the velocity of the blood cells, but we measure the velocity of the tissue. So which tissues? You see, we colorize with the TDI modality, which is there in your machine. With a button, you switch on the button in the apical fourth chamber view, and it colorizes the entire tissues of the heart. So you see, this is the left ventricle, this is left atrium, right ventricle, right atrium. Now, in assessment of diastolic dysfunction, we will measure the annular velocity, mitral annular velocity. Here, this is the mitral annulus. This we call septal annulus, and this is the lateral annulus. This is a cut section of the apical fourth chamber, or cut section of the heart. So this end of the annulus is called the septal annulus, and that end is called lateral annulus. We will need both these annuli. Now, you should know that annulus moves towards the apex during systole, and it moves away from the apex during diastole. So it moves towards the apex during systole, and it moves away from the apex during diastole. Now, before I measure the velocity of annulus, what I do, I reduce the width of the sector. This is because see, we need a very high frame rate while assessing the tissue Doppler velocity. So we need to cut the unnecessary portion and we reduce the sector width. Now I have kept my sector in the septal annulus. This is the septal annulus. So I have kept it there. What I'll do in the next step, I'll get the cursor here, place the sample volume here, and get the tissue Doppler imaging. Now, let us see how it goes. So this is the patient where I got E wave more than the A wave, normal patient, normal diastolic mitral inflow pattern. And I place the sample volume here in the septal annulus. And as I said, the annulus moves towards the apex during systole and moves away from the apex during diastole. So if this is the baseline, the flow patterns above during systole will be above the baseline, and the flow patterns below the baseline are in diastole. Now let us concentrate on the patterns below the baseline, because we are going to analyze the diastolic flow pattern. Now, if you look here below the baseline, this is the baseline. So below the baseline, this is the first major wave. We call it E prime. See, there is a sign above the E wave. So we call it E prime, and we denote with E dash or E prime. And the second diastolic wave is the A prime. So in the septal annulus, what we see that E prime is bigger than the A prime. Here also E wave was bigger than A wave. And in the tissue Doppler, we are also getting E prime bigger than the A prime. Now let us move to the lateral annulus. Again, I have brought my cursor on the lateral aspect of the heart and place the sample volume in the lateral annulus and get the tissue Doppler velocity. But again, I see that E prime is more than the A prime. So it is reflecting, it is almost a reflection of the pulse wave Doppler pattern of the mitral forward flow, where E is more than A, so also the tissue Doppler velocity, where E prime is more than A prime in both the septal annulus and the lateral annulus. Now let us see the that case of hypertrophic cardiomyopathy. Look, here this is that case of asymmetrical septal hypertrophy. Look at the E wave is more than the A wave. Now, as I do the tissue Doppler imaging and take the velocity of the septal annulus, what I see, E prime is less than the A prime. See how E prime has become smaller than the A prime. And so also in the lateral annulus, E prime is less than the A prime. So what we see that though pulse wave Doppler of the mitral forward flow is showing E wave more than A wave, but tissue Doppler never let us down. It is showing the actual picture that E prime is less than the A prime, both in the septal annulus as well as the lateral annulus. So tissue Doppler imaging of this pattern, we say it's a pseudo-normal filling pattern, where forward flow shows E wave more than A, but tissue Doppler shows E prime less than the A prime. Now, when the tissue question of, the subject of tissue Doppler imaging comes to differentiate normal from the pseudo-normal, I must tell you about a ratio which we use to predict the LV filling pressure, and that is E by E prime, where E is the velocity of the mitral forward flow by pulse wave Doppler, and the E prime is the tissue Doppler imaging velocity. Now let us see how we do it. First, we get the mitral forward flow As in this case, we get E wave more than the A wave, and E velocity is 0.99 meter per second. Then next we do the tissue Doppler imaging by switching on tissue Doppler mode and reducing the sector width. We get E prime velocity as well as A prime velocity. And the machine does everything, but you must know, see, we have to know E by E prime ratio. Now here we get it's 24.75. So E by E prime at the septal annulus is 24.75. Now let us move to the lateral annulus. Again, we do the tissue Doppler imaging and take the E prime velocity, and then that calculates the E by E prime, and it is 15.50. Now what we do in the next step? We take the average of E by E prime of septal annulus and E by E prime of lateral annulus. So how much is the value? If we take the average of E by E prime, it is coming out to be 20.12. And as per the latest AEC recommendation, average E by E prime more than 14 predicts raised LV filling pressure, or the raised left atrial pressure. So this patient is having very high LV filling pressure. So this is a pseudo-normal filling pattern having E by E prime 20, average E by E prime of 20.12. So this is the case where the patient is having very high LV filling pressure. Now, next to that, another criteria for indicating the status of LV filling pressure while assessing the diastolic dysfunction is to look for TR jet velocity. Look at this patient. This is a patient of cardiac amyloidosis. Now look, there is a small TR, mild tricuspid valve regurgitation. But even with that mild tricuspid valve regurgitation, I am getting a velocity of 3.15 meter per second. Normal peak TR jet velocity should be less than 2.8 meter per second. So this indicates that patient is having pulmonary hypertension because TR gradient is almost 40 millimeter of mercury. And with that, we add the RA pressure, and we get to know the pulmonary about the pulmonary arterial systolic pressure, and these indicates, even if it is RA pressure is normal, the estimated pulmonary arterial systolic pressure is more than 40, and that indicates raised pulmonary arterial systolic pressure, and that we are getting from the peak TR jet, and that is indicating elevated LV filling pressure. So now if we summarize the parameters till now, we have come across, first of all, we got the LA volume index. We know if it is more than 34 ml per square meter of body surface, we say that LA volume is increased. We also look at the velocities of EA ratio. Then we go to the tissue Doppler imaging. We measure the septal annular velocity, lateral annular E prime velocities, and then we measure the E by E prime ratio to get an idea about the LV filling pressure. We also look at the TR jet velocity. Now, utilizing these parameters, let us see how American Society of Echocardiography has helped us to grade the diastolic dysfunction in the patients with myocardial disease. Here is a flow chart. Though this looks very clumsy, but I will help you to go through it. You see, first you look at the mitral inflow. Mitral inflow, if E by A ratio is less than 0.8 plus E wave velocity is less than 50 centimeter per second, you can straight away say that this patient has normal left atrial pressure or normal LV filling pressure, and these we label as grade 1 diastolic dysfunction. I am showing you an example. This is a patient who is 60 years old male, came for a routine checkup. He is hypertensive for last 1 year. He is non-diabetic. Now, what I do, I get the cursor, put the color flow, get the cursor, place the sample volume at the level of the tip of the mitral valve leaflets, and get the pulse wave Doppler to get EA velocities. Look, E is less than A. E wave velocity is 48 centimeter per second. EA ratio is 0.6. So, as per the latest AC guideline, LV filling pressure is normal or even low if E wave is less than 50 centimeter per second, which is present in our case, plus EA ratio less than 0.8, which is also present in our case. So we can label this case as grade 1 diastolic dysfunction. On the contrary, now just to confirm that yes, this patient is having grade 1 diastolic pressure, we also check for the LA volume index, which is 28 ml per square meter, and E by E prime also shows average E by E prime is only 7.4. So our grading will be grade 1 diastolic dysfunction. Now let us look at the extreme right arm of this flow chart. You see, if mitral inflow shows E by A ratio more than 2, then straight away we can say it's grade 3 diastolic dysfunction, where there is raised LA pressure or raised LV filling pressure. So this is an example. You see that case of cardiac amyloidosis, who was a 56 years old male. He was hypertensive also, non-diabetic, presented to us with shortness of breath in class 2 to 3 for last 6 months, along with bilateral ankle edema. We got hepatomegaly and crepitations. Now this is the parasternal long axis view. You see the left atrium is enlarged. If you can see there, you can even if you measure the anteroposterior diameter, it will be enlarged, and we need to measure the LA volume index also, and look at the myocardium. See, look at the septal wall thickness and posterior wall; those are increased. This is not due to hypertrophy of the myocardium, but in amyloidosis, there is a deposition of the amyloid in between the myocardial layers, so that increases the thickness, and that gives rise to the restriction to the left ventricle, and it makes the left ventricle non-compliant. And look at the short axis; the myocardium is absolutely thickened. Now let us see how the diastolic flow pattern in this particular patient. I kept the sample volume at the level of the tip of the mitral valve leaflets and get the pulse wave Doppler, and what I see, E by A ratio is 6.6. And as per the latest recommendation, LV filling pressure is said to be elevated if the EA ratio is more than 2, whereas in my patient, I got 6.6. So here LV filling pressure is very, very high, and we level this type of diastolic dysfunction as grade 3 diastolic dysfunction. Now, when I say this pattern, I have already explained tall E, small a, short deceleration time. This pattern I am getting in a patient where there is a myocardial disease, which is cardiac amyloidosis. But if you may get in a normal young individual with normal healthy heart, where you get a very tall E and a small a. This is because, you know, in a young heart, relaxation is very, very active. So, you know, that makes the E wave very tall. And most of the filling takes place during early rapid filling phase due to active myocardial relaxation in the young heart, where there is normal ejection fraction, myocardium is absolutely healthy. Still, we may get this pattern, but we never label it as grade 3 diastolic dysfunction. So you must remember that this particular thing is not applicable in a healthy young person with normal heart and normal ejection fraction. So only when there is a diseased myocardium, if we get this pattern where E wave by A wave ratio is more than 2, we label it as grade 3 diastolic dysfunction. And we also look at the L volume index, which was 42 per ml per square meter from the biplane method, 4-chamber and 2-chamber. And we also see the average E by E prime. Look here, E wave velocity is 107 centimeter per second, whereas E prime velocity at the septal annulus is only 2.61 centimeter per second. And here in the lateral E prime velocity is only 2.2 centimeter. That gives us an average E by E prime 44.6. So definitely this patient is in very advanced grade 3 diastolic dysfunction with very high LV filling pressure. So this way we come to we grade the diastolic dysfunction. But situation is not so easy in every case. Now let us look at the mid arm of mitral inflow. Here you look, if we get a pattern in between these two, where E by A ratio is less than 0.8, plus E wave velocity is more than 50 centimeter per second. Here E velocity was less than 50 centimeter. Here in this pattern, E wave is more than 50 centimeter, or EA ratio is more than 0.8 but less than 2. So there may be two situations. One is this, another is this. In these two situations, we cannot comment on diastolic, the grade of diastolic dysfunction by looking only at the mitral inflow. So let us see. A case of hypertrophic cardiomyopathy. This is not amyloidosis. This is hypertrophic cardiomyopathy. Septum is grossly thickened. Here I do the mitral inflow pattern, and I get a E velocity 99 centimeter per second and EA ratio 0.7. So this is basically situation 1. In this particular cases, we cannot comment on the grade of diastolic dysfunction. We cannot comment on the LV filling pressure. We need certain additional parameters to comment LV filling pressure, which I'll show you subsequently. So situation 1 is this. Now let us see the situation 2. This is the situation 2, a case of AMI in the LAD. You see, the apex is scarred. Moreover, there is a thrombus. If you see, this is apical 4-chamber view. So AMI at the LAD territory. Now in this case, what I get, E by A ratio 1.38. So it's in between 0.8. I mean, it's more than 0.8, but definitely less than 2. In this situation also, the LV filling pressure is uncertain and we cannot grade diastolic dysfunction. We need additional parameters to comment on the LV filling pressure. Now let us see what are the additional parameters. These 3 are the additional parameters. One is the average E by E prime. The criteria is it should be more than 14. TR velocity should be more than 2.8 meter per second, and LA volume index positive criteria is more than 34 ml per square meter. Out of these three parameters, if two or all three are negative, we can straight away say that it is grade 1 diastolic dysfunction. If two or three, all three parameters are positive, we are having all the criteria fulfilled, then we say the LA pressure or the LV filling pressure is raised and it is grade 2 diastolic dysfunction. Here you see the E by A ratio 0.7 less than 0.8 and E wave velocity is 73.8 centimeter. So it's more than 50 centimeters. This is situation 1. And I do the tissue Doppler velocity. I get average E by E prime 20.7. So it's fulfilling the criteria. The criteria 1 is fulfilled. Now let us move to the second criteria, TR velocity. I find there is a small TR and TR velocity is 1.48 meter per second. Not fulfilling the criteria. Second criteria is gone. And third criteria, LA volume index should be more than 34 ml and I'm getting 35 ml per square meter. So criteria is fulfilled. So as per the guidelines, if two are positive, my patient is in this group of diastolic dysfunction. That is the grade 2 diastolic dysfunction. Now, see, it happens. Sometimes we do not get all the criteria. Like some patients might not be having tricuspid regurgitation. So what we do, I'm going to show that those cases later on. Now, to make the things simple, AC has come with another chart where the things are much easy to understand. If you find that flow chart a bit difficult, which is not at all difficult, but later on you will understand everything as you read and read. Look at this chart. This is very easy. See, basically the myocard, diastolic function may be normal, grade 1, grade 2, grade 3. So in normal pattern, LV relaxation is normal. In all other three, the LV relaxation is impaired. Now let us look at the mitral EA ratio. Normally it's more than 0.8. In grade 1, less than 0.8. Grade 2, more than 0.8, less than 2. And grade 3, more than 2. Average E by E prime normally is less than 10. So also in grade 1, in grade 2, 10 to 14. And in grade 3, it is given more than 14. Peak TR velocity less than 2.8 meter per second in normal and grade 1 diastolic dysfunction. Whereas in grade 2 and grade 3, it's more than 2.8, indicating presence of raised pulmonary arterial systolic pressure. So all these findings say that left atrial pressure is normal or lower normal in normal diastolic function and grade 1 diastolic dysfunction, whereas the LA pressure is elevated in grade 2 and grade 3. Now, as I told you, in some cases, we may not get all the criteria, like TR might be absent. We may not get very good tissue Doppler velocity, etc., etc. So we need to know some other criteria to comment on the LV filling pressure. One such is the pulmonary vein flow pattern. As you know, there are 4 pulmonary veins which drain into the left atrium: right upper, right lower, left upper, and left lower. And we can assess the pulmonary venous flow, though it is in the far field, it's difficult to visualize, etc., etc. We say many things while assessing the pulmonary venous flow, but in today's machines, the picture quality is so good that you will be able to visualize the right pulmonary vein, at least, if not more. We may see all the four veins in many cases. So this is the right upper pulmonary vein. See, I'm getting the apical four-chamber view, putting the color flow, and the sector is a bit down towards the pulmonary vein. So what I do, I put the sample volume deep inside the pulmonary vein, 2 centimeter inside, and get the pulse wave Doppler. Now, pulmonary venous flow is a venous flow pattern. The flow takes place both during systole and during diastole also. But on top of that, pulmonary vein has got another flow also, that is called the atrial flow reversal. See, this systolic wave corresponds to the ventricular systole, and the first diastolic wave corresponds to the early rapid filling phase. And this atrial flow reversal corresponds to the atrial pump or the A wave. You see, when the left atrial contracts during the late rapid filling phase, most of the blood goes from the left atrium to the left ventricle. But there is a backflow of some amount of the blood to the pulmonary vein because of the LA contraction. So that gives a flow pattern below the baseline, a very small, which we call atrial flow reversal. So if I place the sample volume deep inside the pulmonary vein and get the pulse wave pattern, look, I get the systolic wave and then the diastolic wave. So you compare with the ECG, see my first wave is during the systole and the second wave during the diastole. As you can see, you compare with the ECG. Systole starts from the the beginning of the QRS and ends at the T wave, end of the T wave, and diastole starts from there. So systolic wave is more than the diastolic wave, and this is the atrial flow reversal. Normally, S to A D ratio is more than 1. Systolic is bigger than the diastolic wave. But in a patient where there is a myocardial disease and ejection fraction is low, I am not getting other criteria properly, I get a pulmonary venous flow very nicely, and I can show that systolic wave is less than the diastolic wave, as is happening in this case. You see, the systolic wave is less than the diastolic wave. These indicates that LV filling pressure is raised, but this patient has to have a myocardial disease with reduced ejection fraction. This is not applicable in healthy young with normal ejection fraction. Challenge is always a suboptimal image quality, but as I said, today's machine is very good to show us the pulmonary venous flow pattern. You can always try, and I'm definite that you are going to get a very good flow pattern. Another important pattern to comment on the LV filling pressure is the isovolumic relaxation time. Isovolumic relaxation time. As when I talked about the physiology of diastole, I told you the left ventricle undergoes relaxation, and mitral valve doesn't open till the time the pressure of the LV is less than the LA pressure. So this isovolumic relaxation is the time period between the aortic valve closure to the mitral valve opening. So isovolumic relaxation time measurement is done in the echocardiography. It is very easy to do. We go to the apical 5-chamber, or even the apical 3-chamber view will do. And what we do, we get the cursor and place the sample volume in between the mitral flow. This is the apical 5-chamber view. We say 5-chamber because we have opened up the aorta. This is left ventricle, aorta, left atrium. And this is mitral valve. So what we do, we place the sample volume between the mitral valve and the LV outflow tract so that it detects the mitral inflow as well as LV outflow. Look at this flow. This is the mitral inflow. Here the mitral valve closes, and here is the aortic flow, and aortic valve closes here. So this is documenting both the mitral forward flow and the LV outflow also. Now we know that isovolumic relaxation time is the time from the aortic valve closure to mitral valve opening. Now this is the aortic forward flow. Here is the end point of the aortic forward flow. So the aortic valve closes here. And this is the beginning of the E wave. So mitral valve opens here. I am going to measure this time between the aortic valve closure and the mitral valve opening. So what is the time here? 66.54 milliseconds. Now let us see what is the normal value. Normal value should be less than 70 milliseconds. Now, what happens? See, in grade 1 diastolic dysfunction, it prolongs the isovolumic relaxation time because myocardial relaxation is poor, so LV pressure fall is slow, so LV takes longer time for its pressure to come down, so mitral valve opens a bit late. So that prolongs the isovolumic relaxation time. So if it is high, then it indicates, normal LV filling pressure, because in grade 1 diastolic dysfunction, where there is only relaxation abnormality, LV filling pressure is normal, as I said. So normal or high value of isovolumic relaxation time indicates normal LV filling pressure. On the contrary, if the isovolumic relaxation time is shortened, it indicates the raised LV filling pressure. So if you get a very low value of say 50, then you say the LV pressure, filling pressure is high in this patient. It is very helpful in cases of atrial fibrillation, where we can't measure the EA ratio. We have many problems. So if the IVRT is less than 65 milliseconds in a patient with atrial fibrillation, it indicates raised LV filling pressure. Now, of course, the challenge is tachycardia, because in tachycardia, tachycardia shortens the isovolumic relaxation time, so very difficult to measure. You can increase the sweep of the this flow pattern to measure the isovolumic relaxation time. Another criteria for estimating the diastolic, assessment of diastolic dysfunction is color M mode propagation velocity, or we say VP. So what it is, you see, color M mode means we are utilizing M mode, we are utilizing color. And what is this propagation velocity? You'll have to understand. Now, you see, when the blood moves from the left atrium to the left ventricle, blood is sucked into the ventricle. So normally blood moves very fast from the left ventricular base to the apex. Very fast. Blood is sucked into the ventricle. So instead of pulse wave Doppler, after keeping the cursor across the mitral valve, right at the center of the mitral valve flow, if we get the M mode pattern, we are not getting the pulse wave, we are getting the M mode pattern. What we will see? We'll see two waves two waves. You can see the first wave is due to early rapid filling phase, and the second is due to late rapid filling phase. Now, in the early rapid filling phase, we measure the propagation velocity. What we do, see, this is the mitral valve level. You can see the tissue of the mitral leaflet. So we will start measuring the slope from mitral valve level. We'll go 4 centimeter inside the ventricle and we'll measure the slope. So if the relaxation is very good, the propagation of the blood will be very steep and the slope will be very steep. Propagation will be very fast and the slope will be very steep. So normally VP is more than 50 centimeter per second. Whereas in all other variety of impaired relaxation, pseudo-normal or restrictive, it is less than the 50 centimeter per second. So this is the way we measure the color and mode propagation velocity, and utilizing this VP, we can predict the LV filling pressure. You see, first what we do, we measure the E wave velocity and then we measure the VP, as I have explained, and then we take the ratio of E by VP. If E by VP is more than 2.5, it predicts PCWP at least more than 15 millimeter of mercury, especially in patients with reduced ejection fraction. And E by VP ratio, if it is more than 1.4 in patients of atrial fibrillation, it indicates raised LV filling pressure. So this way it is helpful, but it has got low feasibility and reproducibility, but we can always get the value and it's very easy to do. Now, till now, we were measuring all at rest, whatever criteria we were measuring, mitral flow or pulmonary flow, whatever, we were measuring everything at rest. Now, it has been seen, in spite of being in grade 1 diastolic dysfunction with normal LV pressure, some patients become symptomatic, not at rest, but when they exercise, like when they walk, when they run, they go into heart failure, and that limits their exercise capacity. Now, in this particular group of patients, we proceed for diastolic stress test. And what is that? See, diastolic stress test is the measurement of LV filling pressure by echo with exercise. What we were measuring, what LV filling pressure we were measuring till now, we were doing it at rest. Now we will do with exercise with the help of echocardiography. And this is basically to identify this group of early HFpEF. Look at this graph. See, at rest, if the patient is normal, diastolic function is normal, both at rest and at exercise, LV EDP is normal. You see, it's normal. We have no problem with advanced HFpEF because even at rest, the LV filling pressure is high in those patients. So also with the exercise, it increases further. We don't have to find out this patient group. But the patients who are in early HFpEF, their LV filling pressure is normal at rest. But as they start doing exercise, their LV filling pressure goes high and they go into failure. So these are the patients who are in early HFpEF. Now, why this happens? If we look at the effect of exercise on diastolic function in a normal subject, there is an augmentation of myocardial relaxation with more powerful early diastolic suction in a normal subject. increasing the E wave as well as the E prime velocity, tissue Doppler velocity. So if the velocity of both E by E prime increases, that will keep the E by E prime ratio normal. So normal LV filling pressure. This will indicate normal LV filling pressure. On the contrary, what happens to this group of early HFpEF patient where we get normal LV filling pressure at rest? Now we ask this patient to do the exercise, but unlike this group of patients, this patient has no augmentation of myocardial relaxation. Then how the cardiac output is maintained? Cardiac output is achieved at the expense of increased LV filling pressure. So what happens? Though the E wave rises due to exercise, but no change in E prime, because there is no relaxation of the myocardium, no augmentation of the myocardial relaxation. So that will not change the E prime velocity. What will happen? E is increasing, E prime is not increasing, rather decreasing. So that will increase the E by E prime ratio, and that will indicate raised LV filling pressure. And that is why the patient goes into shortness of breath. So how we elicit this finding and how we identify this early HFpEF patient by asking the patient to do the exercise. It is very, very easy to do in your lab with the help of an echo machine under treadmill. It can be done in the bicycle ergometer, but in India we do with the treadmill test, with the help of treadmill test. So what we do, see here I am doing, this is the step 1, this is the step 2, and this is step 3. In step 1, what I do, I take the diastolic parameters at rest. Patient has not walked. At rest, I am completing the diastolic parameters like E wave, EA ratio, E by E prime ratio, and all those. Then I ask the patient to walk on the treadmill. And patient does the symptom limited exercise. Like as soon as the patient becomes short of breath, patient immediately lies down on the bed with the left lateral position. And again, I take the diastolic parameters after the exercise. Now there is a problem. As the patient walks, patient becomes tachycardic, the heart rate increases, and that causes fusion of the E and the A wave. So what you do, you ask the patient to lie down, keep the probe in the proper position, and within a minute, the tachycardia settles and the E wave and A wave get separated. So you start acquiring the diastolic parameters during that time, within a minute. But then the velocity will not decrease, not the velocity of E wave or E prime. So you can wait for a minute till the EA gets separated. So here is the patient where at rest, I got E velocity 72 centimeter per second, and this is the rest. And during stress, look at the E wave. It has increased to 106 centimeter per second with exercise. And look at the E prime. So see, the E prime was 7 centimeter per second at rest, but it has decreased to 6 centimeter per second at stress. So if we calculate at rest, E by E prime was 9, and with stress, where after walking, E by E prime went up to 17.6. So that is why the patient was short of breath with exercise. Though at rest, LV filling pressure is normal, but with exercise, these patients' LV filling pressure rises, and which is elicited by doing the diastolic stress test, and we see that E by E prime is increased to 17.6, which is quite high, more than 14 So the LV filling pressure is high in this case. So this patient is basically in the HEP group. Another way to elicit this raised LV filling pressure is by doing a passive leg raising test. See, when you are doing the echocardiography and you are suspecting that there may be high LV filling pressure, but actually at rest you are getting normal LV filling pressure. In those cases, what you do, you elevate both the legs passively. You tell your colleague to raise it. You elevate both the legs passively, perpendicular to torso, with the knee bent to about 70 to 80 degrees. That will transiently elevate the preload. This is opposite of Valsalva. It increases the preload, and these will now unmask the elevated LV filling pressure, resulting E by E prime more than 14. So you can easily elicit, you can easily unmask the elevated raised filling pressure in these cases. Moreover, you have an advantage that heart rate is favorable in this case when you do the passive leg raising, because the patient doesn't do any exercise. So there is no tachycardia and there is no chance of fusion of E and A wave. They remain separated. So you enjoy that advantage of normal heart rate. And after knowing all these parameters, you should know the names of at least advanced techniques for assessment of diastolic dysfunction, where we utilize volumetric analysis of LA by 3D. We do LA strain and strain rate by speckle tracking echocardiography, which is an advanced modality. And we also do the global longitudinal strain. We do the global longitudinal diastolic strain also is started. And we do the LV untwisting rate. Now, out of all these, the LA strain and the strain rate measurement by speckle tracking echocardiography has gained importance of late, and because it is an important biomarker again of HEPF, which is a real problem. We face problem to find out this group of patients of HEPF, where echocardiography is really helpful. Abnormal LA strain at rest indicates elevated LV filling pressure, and this is a prognostic marker also, because lower absolute reservoir LS strain was noted in patients with previous hospitalization, and this was found in a prospective comparison of ARNI with ARB on management of HEP trial. However, these require standardization, and for you, you are not yet ready to utilize this. However, this is coming in a very, very big way. You should know the name of a measurement of LA strain. You will see in your machine that we do regularly the strain of global longitudinal strain of LV. Now we are also we have started doing a measurement of the LA strain. So you see, to conclude, I would say that yes, it is a bit lengthy, but assessment of diastole, this is not really lengthy. If you summarize the things what I have told you, and if you have understood, then you will find that assessment of diastolic dysfunction is not very, very difficult. It's quite simple. Only the thing is that it should be done carefully, and you should follow the algorithm as I have explained you. Thank you.
Thank you, Debika, for excellent work out on diastology. I'm sure like many people must have benefited with the talk. Can we have a question and answer session if it's possible? we'll stop sharing the slides, Debika. Yeah. So let's start with the question and answer session, because this is what we were looking forward for the timing. So Dr. Ashutosh, I'll able to enable everybody to. So I'll start with Dr. Ashutosh. You want to ask something about diastology?
Good evening, sir. Good evening, ma'am. I have some problem in understanding of isovolumetric relaxation, that IVT time.
Okay. So we'll share the screen once again.
Yeah, you can share the screen.
Okay. Okay. Ashutosh,
Yes,
please,
ma'am.
please you can interrupt me. Like you see, what is isobalmic relaxation time? First, I think you know that.
Yes, ma'am.
It is the time from the aortic valve closure to the mitral valve opening, right?
Yes, ma'am.
Okay. Normally, it is less than 70 millisecond,
Yes, ma'am.
right? Where there is active myocardial relaxation
Yes, ma'am.
on the mitral valve, uh, the aortic valve, before the mitral valve opening, the active myocardial relaxation takes place. And
Ma'am, which type of window this is? I'm
okay, this
not.
is apical 5-chamber view, where I have opened up the aorta from the apical 4-chamber view. Though aorta is not a chamber, but for the sake of giving the description, we say 5-chamber view, where aorta is considered as a chamber along with left atrium, left ventricle, and there is right atrium, right ventricle. So this is called apical 4-chamber. We get this from apical 4-chamber by fanning out the probe, by anterior tilting of the probe. You see, look, this is the aorta. See, opening
Yes,
up from the left ventricle. Now here, can you see the mitral valve?
yes, ma'am.
Okay. Now we have to find out the time from the aortic valve closure to mitral valve opening. We need to see the time at which aortic valve closes, and we need to see the time at when mitral valve opens. That is possible only from the 5-chamber view or 3-chamber view, where we see mitral valve as well as LV outflow opening.
Okay.
Clear?
Yes, ma'am.
Okay. So next step, we do the 5-chamber, and then we get the cursor and place the sample volume in between mitral valve and the aortic LV outflow. Here, so more or less here. You see here, right?
Okay.
So that will pick up both the mitral forward flow and LVOT flow. Look at this spectral pattern. There are forward mitral flow above the baseline and the LV outflow below the baseline.
Yes, ma'am.
Right?
Yes.
So if you can identify the aortic flow, it begins from here. This is the systole and it ends here. So aortic valve closes here. Clear?
Yes, ma'am.
So isobalmic relaxation time starts from aortic valve closure time. We'll start from here. And then next we will look for the mitral valve opening. This is E wave and this is A wave, right?
Yes, ma'am.
Here you see, this is the E wave, A wave. So where E wave begins here, right?
Yes, ma'am.
So it is here, somewhere here. So this is the time where there is isovolumic relaxation of the ventricle. So we measure the time, IVRT. and it is 66.54 milliseconds. Now tell me, where is your confusion?
This is okay, ma'am. But for the grading, like it is inversely related to the diastolic dysfunction.
Okay, okay. Now the next point. So what I said, normally it is less than 70 millisecond.
Yes, ma'am.
Okay.
Yes.
So now what happens normally? There is active myocardial relaxation.
Okay.
The LV pressure falls quickly.
Yes, ma'am.
Okay, fine.
Yes, ma'am. Yes.
So as soon as LV pressure falls and goes below LA pressure, mitral valve opens.
Yes, ma'am.
So that way, normally the IVRT is kept at more than, less than 70 milliseconds. Now what happens in grade 1 diastolic dysfunction? There is impaired relaxation pattern, right?
Okay. Slow
Impaired,
opening of MP.
uh,
It means slow opening of mitral valve.
yes, there will be, LV will take longer time for its pressure to get it below the LA pressure.
Okay.
Because of impaired relaxation, LV pressure fall is slow. Understood?
Okay, ma'am.
So mitral valve opening is delayed in grade 1 diastolic dysfunction. That will prolong the isovolumic relaxation time, won't it?
Yes, ma'am.
Okay. So impaired relaxation pattern, you have understood? Clear?
Yes, ma'am. Yes, ma'am.
Now, in advanced stage of diastolic dysfunction, what happens? The LV pressure, as I said, in the grade 3 diastolic dysfunction, what happens? LV is non-compliant. LV feeling pressure is high.
Yes.
So, though the LA pressure is high, but LA pressure is very high,
Yes.
First, you think about the LA pressure. The LA pressure is very high in advanced stage of diastolic dysfunction. So what it does, it opens up the mitral valve very quickly. The pressure difference of the LA and left ventricle is high in the beginning.
Yes.
Understood?
Yes.
Because of the raised LA pressure, the opening of the mitral valve is quick.
Okay.
So that will reduce the IVRT. So mitral valve will open up quickly because LA pressure is raised.
Okay.
Normally, LA pressure is normal. So also in grade 1 diastolic dysfunction, where there is only impaired relaxation, LA pressure is normal. Only in grade 2 and grade 3, the LA pressure is raised. So in those cases, IVRT is reduced, especially in grade 3 diastolic dysfunction, where LA pressure is significantly increased, that opens up the mitral valve very, very quickly.
Yes, ma'am.
Tell me now.
Yes, ma'am. But the another scenario in atrial fibrillation, this is different from uh, you know, that LVRT, if it is less, IVRT is 65 millisecond,
Yes.
especially in scenario of AF, then it means it is not normal.
Yes, it is raised LV filling pressure.
Yes, ma'am.
Is it
Debika,
clear?
I'll add a little bit.
Yes, sir. Please.
Normally, IVRT is about 70 to 90 milliseconds.
Okay.
And whenever the LA pressures are raised, the IVRT will fall, shorten down completely. Remember a very simple formula. What is IVRT? Is isovolumic relaxation time. And whenever the diastology, when the LV EDP goes up or LA filling pressure goes up, the shortest possible thing which can happen is the fall of IVRT. If you really go to the pathophysiology, how does it happen? It's quite a tricky thing. You have to understand the interdependence of LV and LA to talk about all these kind of phenomena. And there are multiple graphs based on this, how these pressure curves, they changes completely.
Okay, sir.
And the best part is to remember, like a cutoff mark of less than 70 or more than 70 as a normal routine.
Okay, sir.
60 and 65 is considered a very good value to look at an IVRT. If they are less, obviously the patient has got an elevated LVDP or left atrial mean pressures. We can calculate this by tissue Doppler imaging also. Dr. Debika can show a TDI picture, and like closure of aortic valve and opening of mitral valve, we can calculate by TDI also. Debika, share your picture of.
I'm sharing.
Yeah.
Just give me a moment.
And that appears to be more robust or a better parameter rather than talking of the older method of looking at aortic valve closure and the opening of mitral valve today. Because in one frame, we'll be able to do a perfect measurement of IVRT. Yeah, you can broaden up, zoom it up and go to full screen and show the where the S wave ends and an E prime starts. That's a time interval between.
Oh, okay.
Yeah, this is reasonably good.
Sir, just
Perfect. No, you can share the measurement. It's excellent tracing. You can show the measurement of IV.
see, above the baseline are the systolic wave. These are the systolic wave. Please concentrate on the diastolic waves, which are below the baseline, below this yellow line. So this is E prime, but before that, there is a small wave that is called isovolumic relaxation. So here also we can measure, where we can measure isovolumic relaxation time, or we can measure. You see, this is the aortic valve opening. Systole takes place during.
Yes,
you see, this is the end of systole, right?
Systole. Yes, yes, ma'am.
And here is the opening of the mitral valve, right?
Yes,
So
ma'am.
you can measure from here to here.
Okay.
From here to here. Sir, please explain.
Yeah, it's true. This is what exactly is required. You just measure this time interval, and that'll be great enough to talk about a systolic or isovolumic relaxation.
Relaxation.
Clear?
Yes, yes, ma'am.
It has not become clear to us in the last 30 years. How can it become clear to him in 30 minutes?
Yes.
Madhumita, please go ahead now. It's your turn.
Good evening, ma'am. Ma'am, can you please explain effect of exercise on early HFF patient?
Okay. Okay. I'll.
Meanwhile, Dr. Debika is trying to show you the slides. I'll say many
Yes,
people, they present with the dyspnea on exertion. And like they have a program, they have a lung function test, they have a CT scan test. They're everything in the world the people will do and label them as mild coronary artery disease.
Okay, sir.
And that is not truly a mild coronary artery disease. That is heart failure with preserved ejection fraction with exercise that is known as dynamic diastolic dysfunctions.
Okay.
And look at this guy. She has shown you a classical heart failure limits the exercise. And we have seen very commonly in many subjects where the patient was referred, seen by a cardiologist and finally given up completely, saying that he does not or she does not have any cardiology problems.
Yes, sir.
So, Dr. Debika, go ahead and explain this particular phenomenon.
So, as such, during exercise, the patient goes into heart failure. At rest, he is absolutely fine, but as he does running, he goes into failure. So here, these are the patients where we go for diastolic stress test. So this is basically measurement of LV feeding pressure by echocardiography with exercise.
Okay.
To find out this group of patients, to identify the patients of early HFpEF. As Sir said, lung function test is normal, everything is normal, coronaries are normal, but patient becomes short of breath with walking. While taking the morning walk or the evening walk, patient goes into failure. So we need to find out this group. This is basically, because of the effect of exercise. In a normal subject with exercise, you can interrupt me at any time.
Yes, ma'am.
What happens, there is augmentation of the myocardial relaxation with more powerful early diastolic suction. And
Okay.
that will increase the velocity of both E wave and E prime.
Okay.
Both the blood flow velocity will also increase, and the E prime, which indicates the tissue velocity of the annulus, will also increase. It's because it's a normal heart, good myocardial relaxation. And E wave is increased because of the blood flow is increased, and E prime is increased because myocardial relaxation is augmented, right?
Okay. Yes, ma'am.
This will keep E by E prime
Normal.
showing normal LV feeding pressure. And what happens in that particular patient where LV feeding pressure is normal at rest, but as he does the walking or running, there is no augmentation of myocardial relaxation.
Okay.
Cardiac output is achieved at the expense of increased LV feeding pressure. And how we elicit this? We see that though the E wave velocity is increased due to exercise, blood flow increased blood flow velocity, but myocardial relaxation is not augmented. So no change in the E prime.
Okay, ma'am.
Here we don't see the blood flow velocity. When we assess the tissue Doppler velocity of the mitral annulus, it is the velocity of the, we measure the myocardial the velocity, tissue velocity. It is not the blood flow velocity. So though because of exercise, E wave velocity is increased, but no change in the E prime.
Right.
Yes. So if E is increased, E prime is not increased, that will
raised filling pressure.
Right? That will indicate raised LV filling pressure. And because of raised LV filling pressure, shortness of breath. And we do with the 3 steps. Do you want to know this?
That was clear, ma'am.
Okay.
Ma'am, I've got one more question.
Yes.
Ma'am, TIA jet velocity. Can you please show that slide once again?
Madhumita, at your level, if you look at a E to E prime ratio, it will become more than 2:1.
Yes, sir.
You can say safely that patient is in a heart failure with preserved ejection fraction, and that is known as dynamic diastolic
dysfunction. Okay, sir.
Yes. Tell me, Madhumita.
Yes, ma'am, how do we measure TIA jet velocity?
Yes. See, we go to apical 4-chamber view.
Okay, ma'am.
Or a modified apical 4-chamber view. We put the color flow, get the tear, bring the cursor, and make it sure that cursor is absolutely parallel to the tear jet.
Okay, ma'am.
Often we need off-axis view. It might not be a proper apical 4-chamber. We tilt the view. Our whole idea is to make the tricuspid regurgitation flow parallel to the cursor. Clear?
Yes, ma'am.
Only with that, you will be able to get the exact velocity. And we get the continuous wave Doppler across the tear jet. And Above the baseline is the tricuspid forward flow, and below the baseline is the tricuspid regurgitation, because it's coming back
Yes,
below
ma'am.
the. This is the tear, and we measure the peak velocity of the tear jet.
Okay, ma'am.
Okay. Anything else?
Yes, ma'am. Restrictive pattern of mitral inflow. Can you explain that once again?
How can this TRZ velocity related to the diastole dysfunction of left ventricle? RVSP, right ventricular systolic pressure, will relate to the left ventricular
This is
diastolic dysfunction.
one of the causes of tear.
Excellent question. Like this is known as
Very
pre-capillary and post-capillary pressures. Where does the ultimate LA pressure will reflect to? From where the blood is coming to LA?
Pulmonary vein.
Pardon?
pulmonary veins. Yes, yes.
Perfect. Pulmonary veins. And in pulmonary veins, where the blood will come?
For lung.
And
Means
in
for
lungs? Where the blood will come in the lungs?
from left ventricle.
Left ventricle to
Right ventricle.
No.
Right ventricle.
Right.
right ventricle. Correct. If the blood will come from the right ventricle, if the LA is overloaded, what will happen to the right ventricle?
Pressure will
Pressure changes will happen in right ventricle, and those pressure changes will be reflected by raised pulmonary artery pressure or raised TR jet gradients.
okay, sir.
Many patients of you must be seeing right now who had their mitral valve. What we done about 10 years, 20 years down the line, we never looked at their PA pressures, and now those people are coming back with isolated right-sided failures. So that is the basic concept is. And when we look at this LA pressures, on left side, these LA pressures are elevated in left-sided pathologies. When is isolated right-sided pathology, the left-sided pressure will not be elevated. And that's what we call pre-capillary and post-capillary.
Okay.
So don't get confused.
And sir, the jet is very mild, but the velocity is very high. What's the
Jet is
reason, sir?
mild because of two reasons. The RA pressures are pretty high. Look at the RA pressures. RA pressure is huge RA. So what will happen to RA pressure? That will be seen by IVC. RV pressure is pushing up blood into the RA. So the jet would be mild. And second is the Nyquist limit over here is 87. If I'm correct, 87. The Nyquist limit has to be brought down to approximately 50 to 60 in between, and then optimize the color. Then you will see a good TR jet gradient. Intermittent, you can see this TR jet blue color right over here. Third important point, we are looking at only one section of the tricuspid regurg. In one section of the RVRA. RVRA is not one section. RVRA is a three-dimensional structure. We do not know whether the posteriorly placed jet may be causing all this. Fourth important point, RV tricuspid valve is trileaflet valve. It's got a septum, anterior and posterior valve. So the direction of jet could be in some other format also. But once we do a Doppler, Doppler will interrogate any jet velocity. And that is the reason when we look at a very small, tiny jets, you get a good Doppler spectrum pattern as shown by Dr. Debika. Doctor, go ahead.
Hello, is it clear, Madhumita?
Yes, ma'am.
Okay. Any other question?
Ma'am,
Anybody?
restrictive mitral flow pattern. Can you explain that once again?
Right. Restrictive.
Restrictive is nothing but grade 3 diastolic dysfunction. All E, small a. Remember a very simple formula for you.
Okay, sir.
She's going to show you that. If your EA ratio is more than 2:1, like more than 2, then consider that as possibly a restrictive following patterns.
Okay.
We're working in level 1 right now with you. When we'll talk of a level 3 or level 2, things will change automatically.
Okay, sir.
Here is the example.
Yes. See, Madhumita,
Yes, ma'am.
so this is the apical four-chamber view. I have put the color flow to guide my cursor, and then I get my cursor and place the sample volume at the level of tip of the mitral valve leaflets.
Okay.
And the pulse wave Doppler. So in restrictive pattern, there is very tall E,
Yes, ma'am.
small deceleration time, and small a.
Yes, ma'am.
A is almost tiny, you see.
Mhm.
Yes. So what is your question?
Ma'am, this reason for tall E.
Okay, reason for tall E. Now, in restrictive pattern, what I said, it's an advanced stage of diastolic dysfunction, right?
Yes, ma'am.
LA pressure is very high,
Okay.
very high. So what happens? Because of very high LA pressure, mitral valve opens
Yes,
quickly,
ma'am. Quickly. Hmm.
and blood flows from the high pressure LA to the left ventricle
Okay.
with a very, very high velocity.
Hmm.
But since LV is non-compliant, the
Yes, ma'am.
deceleration is quick
Okay.
because there is quick rise of the LV pressure. Understood?
Yes, ma'am.
So there is quick deceleration that makes tall E short deceleration time, but A wave is still small, though much of blood is still remaining in the left atrium. But
yes.
left atrium, in spite of having very high pressure, is unable to empty its blood to the left ventricle
Yes,
because left ventricle is non-compliant. It is not ready to receive the blood from the left atrium.
Yes, ma'am. Okay, ma'am.
Okay, so A wave is very small. Is it clear?
Yes, ma'am. Thank you.
Okay. Sir, would you add something, sir?
No, that's fair enough, Dr. Debika, that's fair enough. Like at your level, like at their level, they're asking a very good question. That's the best part of this particular phenomena of diastology. And it's not really a diastology, it's active systology diastology. So can we move on to Dr. Thinton? Dr. Thinton, you'd like to ask something?
No, thank you, sir.
None? Okay. Dr. Chow Thu.
No, sir. Thanks.
Okay, thank you. Dr. Keen, Ong Kyo Keen.
No, sir.
No, sir. Dr. Ashwini More.
No, sir. I had a question regarding IVRT. It is clear now.
Okay. Dr. Shamshad.
Thank you, sir.
Sir, in case of HOCM, there is a asymmetrical septal hypopy, that is clear. But what happens in systolic anterior motion of mitral leaflets?
Look, I'll take up this question.
Yes.
This question is possibly like he's talking about, Dr. Ashwini is talking about, in hypertrophic cardiomyopathy, systolic anterior motion of the mitral valve happens. Is that right? Dr. Shamshad, can you open up your mic?
Yes, sir. Yes, sir.
So, during this systolic anterior motion of the mitral valve leaflets, the mitral valve remains opened up and severe MR is present.
Okay, sir.
This is only happens when you have a significant left ventricular hypertrophy or a septal hypertrophy. Many cases where only apical hypertrophy is present, you may not have this kind of phenomena where hypertrophic obstruction is not there.
Okay, sir.
So hypertrophic cardiomyopathy could be non-obstructive and obstructive, both of them.
Okay, sir.
Anything else you want to ask?
No, sir.
Okay. Let me move to Dr. Meenakshi. Dr. Meenakshi, you want to ask something? Dr. Sovereign Rai.
Good evening, sir. Diastolic dysfunction सर हाइपरटेंशन डायबिटीज और कार्डियक डिसीज से सर कैसे कोरिलेट करेंगे? मतलब किसी को हाइपरटेंशन पहले था तो था पहले, मतलब मेरा कंसर्न ये है कि सर कई बार क्या होता है डायस्टोलिक डिस्फंक्शन मतलब आता है, इसके बाद भी बीपी नॉर्मल रहता है, तो ऐसे में मेडिसिन वगैरह देने की नेसेसिटी है या नहीं है सर?
He has got a very good question, Debika. He is asking, suppose somebody has got hypertension or diabetes or something like that.
अच्छा कंटिन्यू रखिए, क्या प्रॉब्लम हो रहा था? फीवर? अच्छा, कितना दिनों से?
Dr. Shamshad, please unmute yourself.
5 days हो गया.
Okay, Dr. Sovereign, your question is like somebody has got a hypertension, diabetes, and blood pressure is controlled, sugar is controlled, but still you have a diastolic dysfunction. So would you like to treat that particular patient? That's what you exactly mean by?
जी sir.
Perfect. A very good clinical question. Dr. Debika?
Please take this.
Okay. What happens, Sovereign, if you have a hypertension, diabetes, sleep apnea syndrome, hypothyroidism, obesity, aging population, if you find a diastolic dysfunction, you have to treat them. What do you mean by diastolic dysfunction? Diastolic dysfunction means elevated LA pressures. Normally is about 8 to 10. When it's grade 1, is 10 to 12. And the most important thing, when it becomes more than 15 millimeters of mercury, that's grade 3 or 4. In those cases, we do use drugs which reduces their LA pressures or preload. And the commonest drug which reduces the preload are, what are the drugs which reduces the preload, Sovereign?
AC inhibitors.
Perfect. AC inhibitor, ARBs.
Ji sir.
Do use these drugs very commonly in day-to-day practice.
Ji sir.
Similarly, if you have a patient, hypertension is or her blood pressure is about 200 by 100 millimeters of mercury, he comes to you and he finds his elevated LA. The drug of choice would not be a beta blocker. The drug of choice would be ACE inhibitor diuretics first.
Thank you, sir.
All right. And Debika, can we go back and show us slides? And there's somebody who's, I couldn't pick up that name. He or she, sir, my audio is not working. I want to ask from where to where I should ensure LA measurement here. Excellent question, Debika. Can you just show that slide again?
Yes, sir. Sir, you want to say, sir?
How to measure LA volumes? Just show you how to measure the LA volume. Go to 4-chamber. Yeah, perfect. That is what she's looking for.
So we measure the LA volume index by biplane area length method, we say. By biplane means in apical 4-chamber and apical 2-chamber. So these are the two planes. This is the 2-chamber view and this is the 4-chamber view. So in apical 4-chamber, we will measure the LA volume in its maximum volume. That means end systole. Just before the tricuspid valve opens, LA will be in its maximum volume. So we will measure the area by tracing it. We'll start from the septal annulus. We'll trace, we'll go round and round following the endocardial margin, and we'll go up to the lateral annulus. The machine will join these 2 points. You have to be careful not to go inside the pulmonary vein, not to include the LA appendage if in case it is opened. So this way we get area 1, and then we get a length in apical 4-chamber. We repeat the same method in the apical two-chamber view, where we measure the area 2, tracing the endocardial margin of the left atrium from one annulus to another, and also the length. Now we get area 1, area 2, and out of these two measurements of length, we will take the smaller value. And the difference should not be more than 10% in these two measurements. Now, with application of this formula, 0.85 multiplied by area 1 multiplied by area 2, dividing by shorter value of length, we get the value of LA volume. So 0.85 is fixed, area 1 into area 2, and out of these two, we get the smaller L value. That will give us some value, and we index it to the body surface area. And upper limit of normal is 34 ml per square meter body surface. Is it clear, Madhumita? I think she's not been able to talk. Sir, you want to add something?
Am I
No, it's
audible?
okay. Fine. It's perfect.
Am I audible, ma'am? It's talking
Yeah.
Yeah. Yes, Madhumita, I can hear you.
It's
Meenakshi, she's
ma'am.
Meenakshi.
Ma'am, I want to clear what are the starting and ending point of L.
L. Okay, though the machine measures it, but still I'm making it clear that it is the maximum length of the left atrium, and the machine measures it from the middle of the line, which the machine gives by joining these 2 points of annulus to the base of left atrium.
Superior margin of left atrium.
Yes, superior margin of the left atrium.
Okay. And to the tip of leaflets, tip of mitral leaflets.
Not tip of the mitral leaflet, line joined by 2 annulus, medial and lateral annulus.
Okay, sir.
Tip of mitral valve is here, and L starts from here. Can you see that green line, Meenakshi?
Yeah, ma'am, yeah.
So it is starting from that center of that green line to the superior margin of the left atrium.
Okay, thank you, ma'am.
Clear?
Yes, ma'am, very much.
Okay.
Okay, anybody else like to ask some questions before we break for it?
Yes, I'm Dr. Pawan.
Pawan, go ahead.
Sir, my question is based on my curiosity. Actually, I heard you on diastology in last sessions. You mentioned the importance of the atrial kick reversal time in differentiating the grade 3 and grade 4 diastolic dysfunction very stressfully. But madam did not mention it anywhere. Has it lost its significance now?
No, it has not lost its significance. We thought you're not so intelligent enough to understand the grade 3, grade 4 diastolic dysfunction. I never knew Dr. Pawan Agarwal would be there. So,
but sir, you mentioned very stressfully this thing.
I mentioned one more thing. Yeah, I only mentioned one more thing is when you have a grade 4 diastolic dysfunction, your train to mortuary has already left. There's only the reach over there.
Yeah. But that is still relevant.
It is very relevant when the atrial kick duration is more than A wave duration. That grade 4 diastolic dysfunction, that is non-reversible diastolic dysfunction.
Yeah.
And it's very seen many times, like you have to identify it. That's all.
Yes. You mentioned it, but madam did not mention it. So I thought, has it changed any criteria? Or not?
No, it's not changed any criteria. You look, diastology and aortic valve, they are the burning issues every time in echocardiography. Believe me, nobody has learned aortic valve disease, especially the aortic stenosis, and none of us have learned diastology till date.
Thank you, sir.
Anybody else who would like to ask something? Because a couple of people are using some code names like CZ. We cannot identify them. ZLK, even that is not identifiable. So anybody would like to ask some question? 1 plus 7 Pro also is 1 over there.
Sir, in clinically, it is always necessary to do an tissue Doppler because in young age, if the E wave is more than A wave, then no need to do an tissue Doppler. But in old age, patient comes with hypertension, but we found that E wave is more than A wave, then we only do the tissue Doppler.
We should do
Hello?
a Doppler. Today is a circumstances that we should do a tissue Doppler.
Always, sir.
Always. It's an inherent part of every machine today.
Okay, sir.
I know you are busy practitioner. You don't have a time to measure all these things, you know. But believe my words, when you start utilizing all these things in a clinical practice, and then it'll be very good to have these things measured in that fashion, you know. And I can tell you, like in your clinical practice, these diastology is going to make a lot of difference. Large amount of a difference.
Yes, sir.
I can quote an example. A lady from a very famous CDOC center in Fortis in Delhi had come. And you know what was? She was having persistent tachycardia. And she used to get breathlessness after walking a certain distance. Somebody did an echo. They did an echo in the routine fashion where they could not evaluate a diastology completely. She was referred to us by somebody from a South Delhi. She traveled a distance of almost 50 kilometers, came down to our center. And what we did, we just asked her to walk on a treadmill for a certain duration. She became really breathless. And at that time, her diastolic function had gone to level grade 3. There are 4 parameters that are there when we talk of this diastology today. Tall E, small a, E prime septal less than 6, E prime lateral less than 10, and TRZ gradient of more than 2.75 meters per second. All of them were present. We just switched over her beta blocker. She was on beta blocker at the time to ACE inhibitor with diuretics. And she came after 4 to 6 weeks and she was absolutely fine. You know. I can quote many examples. One of my residents' mother had the same problem. She used to get dyspnea on exertion. And she had all the tests in the world. And when the dynamic diastolic dysfunction, she was positive for that. And we just built up our ACE inhibitors with ACE inhibitors. And it's almost how many years are there now? 15 to 20 years. She has been doing really great. 2001, yes, exactly 20 years now.
Okay, sir.
So it is really, really a clinical echocardiography. Only thing is you need to spend a time and always say these words. If you're a clinical practitioner, spend your time judicially. Morning, take your rounds for a hospital, wherever you are doing. Every one of you have got a nursing home. I know about it. Morning nursing home rounds, then OPD, and then do OPD. Cut down your OPD in such a fashion. I'm going to look for 4 hours, 5 hours of OPD. Make your diagnosis, do your echoes. Then in 1 or 2 hours, do your echoes. Then evening down and say thank you. 2 things will happen. Your practice will flourish more. And there'll be a waiting line for your patients to show you in OPD consultations. The name will spread. Oh, doctor साहब के पास तो बहुत भीड़ होता है. जिस मिठाई की दुकान पे लाइन लगी होती है वही मिठाई बिकती है दोस्त. जो खाली होती है कितनी भी अच्छी मिठाई हो वो नहीं बिकती है. तो लाइन लगाओ, कुछ एको करोगे, कुछ पैसा वहां से आएगा और नाम भी स्प्रेड होगा. और फिर say thank you to Debika. She told you about diastolic. Don't forget her. Any other questions by anybody? ZLK. I'm sorry, I'm pronouncing your name like that.
No, sir.
No, sir. Okay, thank you. CZ. All right, Debika, thank you very much. Excellent presentation as usual. And I'm enlightened, like the way you have really done a wonderful job today by talking about diastology and the mind scratching or the head scratching questions coming from all the participants. That is the most important part for any lecture. If no question comes, then you take it for granted that whatever you have done is not correct. So many questions have come, so it's positive, definitely positive. So I'll put an end. Stay safe. Thank you very much. Yeah, Debika, you want to say something before the closing remarks?
Thank you very much. And good night to everybody.
Good night to everybody. Stay safe. Bye-bye.